We are more toward the end of our formal slide set, so I wanted to maybe just get to some questions, and I can, of course, talk about the next steps here. But I think what a lot of the audience wanted to ask pertain to the presentations we've heard about already. Both Philippe and you have presented some early results and then some longer-term results with the MINIject, both internationally as well as in Europe as well. I think it's encouraging. I will, of course, again, as the audience knows, these are early studies right now, and we're encouraged by them, and we're looking forward to seeing, and we'll talk a bit about next steps later on. So some questions I want to ask to Philippe, to Paul, to Julian that have come up here pertain to endothelial cell loss, because this is a concern that came with regards to the CyPass. Do you think that it was the rigidity of the material that caused the cell loss, or was it the length of the stent into the AC? That's one part of it. And the second part of it is, what about the risk of iris structures or synechia growing over the implant if the implant is so close to the spur, meaning 0.5 millimeters? So two questions. One pertains to the reason for cell loss with CyPass, length or material, rigidity. And second part of it is, well, if you're placing the MINIject deeper in the AC, like 0.5 millimeters, is there risk of synechia formation? So I'm not sure who wants to take those questions. Maybe we can have. Okay, go ahead, Philippe.
Oh, as Julian said, there is no implant migration. So if you put the implant right in the good place, it doesn't move. We have learned with the CyPass that the risk of corneal edema and corneal damage was directly related to the number of rings which was in the anterior chamber. If you put the MINIject implant in the right position because there is no implant migration, there is no risk of corneal touch or corneal inflammation, which may induce some ECD loss. So it's very different. And with the CyPass, because it's very, very rigid, maybe it's not possible to put the implant right in the place.
Paul, any thoughts on these questions pertaining to the differences and synechia formation, cell loss?
Yeah, no, I think it's a great question. I think it's no doubt, as Philippe mentioned, it was related to length, number of rings. The question that comes up is if you had a softer material and you had that same length, would you have the same endothelial cell loss? So to answer the question of the material, you'd have to have the same length and have two different materials and see what happened. But I do think it's a combination. I think it's no doubt the longer it is in the AC, the more potential it has to irritate the endothelium, whether it's rubbing or not. But I think that non-flexible polyamide material did allow more potential for it to rub against the corneal endothelium. So I think it's a combination of the material as well, of course, as the length of the eye. And as Philippe mentioned earlier with the animal studies, there's definitely a decreased risk or decreased formation of inflammation and fibroblastic growth. So I do think that as long as you have enough space between the scleral spur and the tip of the stent, I don't think you're going to see significant PS formation. And we'll have to wait and see, of course, but that's my thought.
Good. Julian, anything to add to that comment?
Well, I fully agree. So it's rigidity and the length of the device in the anterior chamber. So I published a couple of years ago my thoughts on this regarding the CyPass. So I think it's very clear. And there is, again, a very clear difference between the CyPass material and its rigidity and the soft material of the MINIject. And I've shown you the UVM images before, so it's very clear.
I agree. So a couple of my comments on this. I think that it's easy to kind of put all the supraciliary procedures into one bucket because of the experience with one device. But like any procedure we're doing, a lot of it is dependent on the device itself, how it's placed, surgical technique, the design, as we heard, the material, everything else that plays a role in this. And I think that from everything I've seen, and to be fair, we have 2-year data, so we're looking forward to longer-term data to support these conclusions. But from what we've heard so far and what we've seen so far with the flexibility of the device, the way it's placed in the anterior chamber, the way it conforms, there was a question about migration again or compression. I think that although it is flexible, it does conform and it does have its own capacity, and I think that really just ensures that it doesn't get blocked or potentially limit flow. I think all of these improve the reliability and improve the safety of the procedure, which is what we're really after here. In terms of the deeper placement than what we're talking about, 0.5 millimeters, I think that 0.5 I think it seems to be reasonable enough. We have 2-year data now to support that the implant is well positioned and well tolerated. I think that of course we are doing them in eyes that have open angle glaucoma. I would just again caution that this is the kind of eye we studied. We don't know how it will perform in angle closure. Most MIGS procedures are not designed for angle closure, so I want to be careful before we jump to those. But I think in average anterior chamber depths, 0.5 millimeters is well clear. 0.5 is quite reasonable, and it does again conform to the sclera, so it does allow itself to kind of position itself between the iris and the cornea. So that's what I would say to that question, which is a good question. Some questions here that pertain to: is there a best clock hour to position the implant? Do you feel like the implant should be positioned at a certain clock hour to improve efficacy, or, as the questioner was asking, in terms of rubbing of the eye, should it be in the superior quadrant to avoid potential issues? Any thoughts given to this in terms of safety or efficacy, in terms of where the best position for this implant is in the supraciliary space?
Well, I think, when we implant it, try to avoid 3 and 9 just as much as possible because of the vascular plexus. So from a heme reflex, I think that's probably, to me, the most important issue. I don't know really if there's any significant benefit of going superior nasal or inferior nasal, but I think that vascular plexus is all I'd probably be more concerned about.
Yeah, I think, when it comes to trabecular outflow and trabecular stents, we have some thoughts that, of course, the episcleral veins, which are variable in everyone's eye, the proximity of placing a stent near an episcleral vein or an aqueous vein is likely to be helpful because the resistance is lower in that vein. But because supraciliary space is a large resorptive space, the positioning shouldn't really matter where it's positioned in terms of efficacy. In terms of safety and things, again, I think because this is such a soft implant, I think that because it conforms nicely with the globe, I think that the risks are minimized in terms of even with eye rubbing. Although I think in general we know that eye rubbing is just generally not a good idea, even in normal patients without having surgery. So, but I think that minimizes the concern of the risk. There's a question here that has to do with multiple devices. Could they be implanted in the same eye? We've done that, of course, with other MIGS devices. Thoughts on this? Would you consider doing multiple devices at the same time or sequentially? Anybody thought about this in this area?
Well, my only concern with that is that I think when you implant something into the suprachoroidal space, you're in a sense priming the space. So probably that's my feeling. So I don't have hard data to show. But if you do multiple implants, probably the success rate will be lower and lower. So I don't know your thoughts, but no, I don't know.
Yeah, the question is, are you maxing out if you have good outflow through your one, let's say MINIject? Do you need a second one to maximize, to increase the outflow? And I'm not sure if that would be a truism or not. I think one would be enough if it's flowing well to maximize outflow to that space because of the negative pressure gradient. The question comes up is, do you want to do something in the TM as well at the same time? And do you want to combine different mechanisms? But I think from my perspective, I think I would be pretty comfortable with performing one and then waiting and seeing after that.
And if you do multiple intervention with several MIGS, you have the risk to narrow the barrier between efficacy and safety. Because if you do more surgery, you have the risk to have a chronic hypotomy, and after that you won't be able to solve the problem because you won't know which MIGS is involved in the hypotomy.
Yeah, just a quick comment on Ike on the power of the IOP reduction. I mean, back to Philippe and Julian's presentations. I mean, these were not non-washed out. These were not washed out. So these are patients on medications at a pressure of 24, 25. So when we look at all the different MIG studies, they're all washed out, like you mentioned earlier. So that's pretty powerful. On meds, non-washed out from 24 down to 14, and 50% of the patients off of medications. And that's a significant power that we don't see with other conventional outflow MIGS procedures.
Yeah, I think that's a really good call out on the studies in terms of comparing them. These patients were not well controlled. These weren't patients who were controlled on medications, washed out, and then done. So that's again further emphasizes the importance in the results in terms of efficacy. I think that the multi-implant one is an interesting one. I don't think theoretically is necessary because again, once we access the supraciliary space, we can access the entire space certainly and the resorptive capacity of it. I think that Philippe is probably right that I don't think we need to put more than one in at one time. So I don't think that's something that is necessary theoretically either. And then doing it sequentially, as kind of Julian said, I think once you kind of access one outflow pathway and if it didn't work, then I don't know if I would want to achieve that the same way. We may want to go to another alternative pathway as well. So that's a question that is a good one there. Okay, so I'm going to move on to next steps because I know that we're kind of toward the end of our webinar, and I know that Philippe probably has to leave because he's such a busy guy in France doing great work. So thank you for being here, Philippe. If you can stick around, we'll see you. Otherwise, thank you for being here. I want to go to next steps and just speak about what's happening with the design because, of course, we've seen some of the early results with the STAR 1 and STAR 2. If I can go to my next slide, I want to just share with you that currently there are a few projects underway that it looks like in the European market, at least the CE approval is on track for 2021. There's a regulatory program present in the US that will commence soon and will then give us and inform us, of course, with important data for approval. And I think this will continue to expand its usage. One of the things that's important to remember with this device is the data that we've shared so far have been without cataract surgery. So the confounding effect of cataract is not present in looking at the results. On the same time, we know that there's certainly reasonable opportunity to potentially combine it with cataract surgery, and so we need to have more data to look at this, of course, in the future. So let me just summarize here, just as we conclude here. We've talked about where do we stand with MIGS. MIGS, of course, is predicated on safety. Different pathways have different safety parameters, and different pathways have different efficacy. And our goal is to maintain high safety, prioritizing this, but trying to achieve perhaps more efficacy. Paul very nicely talked about some of the differences in the physiologic outflow between trabecular conventional and supraciliary uveoscleral, and taking advantage of the negative pressure gradient, the large space that can be designed with these procedures to take advantage of this outflow track as well. But we need to consider when we use this space that we need to control for fibrosis and wound healing, like any space, of course, but again, pertaining to this space as well. I spoke a bit about the STAR material, and the benefit of this design is biocompatibility, its reduction of inflammation and encapsulation that may occur, the delivery of the device itself that can be performed here surgically with an ab-internal blood-free approach. And then we appreciate Philippe and Julian speaking about the STAR 1 and STAR 2 results. Again, I would say they're promising results. We need, of course, longer term and bigger data sets to give us and inform us more on where this fits. The efficacy certainly seems to be very, very good. And with, again, significant medication reduction, IP reduction, particularly patients, again, who were pretty high pre-op already on medications, as Paul alluded to. Thus far, we have not seen concerns around endothelial cell density loss, which, again, is something now that we have thought about, of course, for these procedures that we will need to consider and prioritize safety. So that's some good promising results. I think that what we hope to see, of course, with this device is a new procedure, a novel procedure, novel device material that can provide safe and effective pressure lowering and fill that gap and that void. I think there's an opportunity for a lot of these mixed procedures to be used. And remember, in a patient's lifetime, they will require multiple therapies, multiple drops, lasers, one or two different mixed procedures, a subcons procedure, something more traditional, maybe a tube. I mean, we need to consider, of course, the long-term control of the patient's pressure, and we may need to use multiple different ways to do this, and the ability to do this, again, with different outflow targets is important to consider. So we're excited about revisiting the supraciliary space. We're excited about the data that's going to come forward, and again, we encourage you all to keep a close watch on this. The 24-month data is being submitted for publication very soon, and we'll be seeing that data published, and you'll be able to read those papers as well. So thank you. We weren't able to get through all the questions here. I think that there's some good thoughts that came through here. I appreciate everybody listening in. Stay tuned. We'll be seeing you at more webinars, of course, throughout this year. I hope that we get back to work soon. and get back to taking care of our patients. For those of you that are still not seeing patients regularly, always good to see you guys. Have a good morning or a good afternoon or a good night, wherever you are. And peace and love to everybody. Stay secure and safe. Thank you very much. Thank you for iSTAR for allowing us to present your results, and we appreciate everyone's attendance.
Thank you, everybody.
Thank you.
Gracias.
Thanks a lot.
Bye-bye.
Bye-bye.